Hi friends, I welcome you all for this session.
In this part 2 video, we are going to see about both solid and cystic lesions that can occur in placenta and their ultrasound diagnosis. Let's move on to solid masses in the placenta. To call it a solid mass, the lesion should be well circumscribed and containing echoes either completely solid or solid with cystic component. When we evaluate a solid mass on the fetal surface of the placenta, two main possibilities has to be kept in mind. One is chorioangioma and the other one is placental hemorrhage or hematoma. Now, how do we differentiate between both these conditions? Here is where the color Doppler plays an important role. Presence of arterial or venous flow within the lesion strongly supports the diagnosis of chorioangioma. On the other hand, the absence of flow is not conclusive, as some chorioangiomas may still appear avascular. Therefore, the grayscale imaging alone cannot reliably distinguish between any chorioangioma or placental hematoma. Another important point is that the appearance of placental hematoma changes with time as the clot retracts. This temporal change on follow-up scan supports the diagnosis of hematoma. In contrast, a true chorioangioma typically maintains a more stable appearance. Now let us see about chorioangioma. It is one of the most common benign tumor of placenta, reported at around 1% of the pregnancies. The first ultrasound diagnosis was described by Ashokan et al. In 1978. On ultrasound, these lesions are usually well circumscribed, and the echogenicity is different from the placenta in that it slightly appears hypoechoic when compared to the placenta. The tumor may have variable size and shape, and the larger ones sometimes divided by the fibrous septa. They commonly protrude into the amniotic cavity from the fetal surface, and they are often close to the site of cord insertion. The red arrow in the picture indicates the presence of fibrous septa in large chorioangiomas. Small chorioangiomas are typically incidental and asymptomatic, while the clinical manifestation becomes significant when the tumor size is large, generally more than 4 or 5 centimeter according to various literature. While these small tumors are seen within the parenchyma of the placenta, the larger tumor tend to protrude from the surface of the placenta into the amniotic cavity. Histologically, chorioangiomas are considered as hematomas arising from primitive angioplastic tissue of placenta. There are three microscopic patterns: angiomatous, cellular, and degenerative type. While angiomatous is the commonest one, it can also be associated with the other types in combination also. In angiomatous type, there can be numerous small blood vessels and capillaries surrounded by placental stroma. In cellular type, there can be abundant endothelial cells within the loose mesenchymal stroma with ill-formed vessels. And degeneration can be necrosis, calcification, hyalinization, and myxoid change. How to evaluate vascularity in chorioangioma? The PRF of the color Doppler is adjusted at 25 centimeters per second for arterial flow and at 10 centimeters per second for venous flow. The wall filter should be set at medium level to reduce the motion artifacts. Remember, the feeding vessels are nothing but the chorionic or parenchymal vessels that directly perfuse the chorioangioma. Now, regarding the pattern of vascularity, it can be sometimes avascular with no internal vessels, and in some cases the vascularity may be in the periphery as shown in this figure 1, and there can be even a single large central feeding vessel as in figure 3, or it can be a highly vascular tumor with multiple large vessels coursing throughout the lesion as in the figure 2. Evaluation of vascularity in chorioangioma is very crucial, as it not only aids in differentiating from other solid placental masses, but also it provides important prognostic information regarding the risk of developing maternal and fetal complications. Now, understanding the pathophysiology of chorioangioma will guide in looking for evolving complications. Now, what happens here is the blood from the umbilical artery enters the tumor, passes through the abnormal AV shunts within the tumor, and then drains back via the umbilical vein into the fetal heart. This creates two simultaneous challenges for the fetus. First is that the preload of the heart is increased because of high venous return, Second, the fetus must also meet the metabolic demand of this extra tissue, that is chorioangioma. So to cope up with this increase in preload, the fetal cardiovascular system responds by increasing the contractility and increasing the heart rate, thereby increasing the combined cardiac output. And this is the reason why we see hyperdynamic circulation with fetal tachycardia, cardiomegaly, and hypervolemia. However, if the tumor grows larger or when the vascularity is more to the tumor, the demand continues to rise, and eventually the fetal heart cannot sustain such increased workload, and it will lead to a high output cardiac failure, and in advanced stages even hydrops fetalis. To sum up, the fact that the fetus supplying a big chunk of extra tissue as well as the increased vascular shunts within this tumor leading to increase in preload is the fundamental mechanism behind the complications of chorioangioma. Now let's move on to the complication associated with chorioangioma, especially large and vascular tumors. Fetal anemia may develop due to several mechanisms such as sequestration of blood within the tumor, or can be microangiopathic destruction of RBC within the vascular network, or sometimes even due to the feto-maternal hemorrhage. Sequestration of platelets can occur similar to RBCs, resulting in thrombocytopenia also. As we have seen in the previous slide, there is hyperdynamic circulation as a result of AV shunting, and this may finally lead to fetal heart failure, hydrops, and placentomegaly. Polyhydramnios is another common complication. It may result from increased urine output caused by the hyperdynamic circulation, or it can be because of the anemia, which can be caused by hemolysis or fetal-maternal hemorrhage or hemodilution, or it can be because of the cardiac decompensation due to shunting, or even from transudation of fluid across the tumor surface. Often, more than one mechanism acts together generally. Maternal mirror syndrome is one of the possibility. Fetal growth restriction can also occur, and the underlying mechanism is the preferential shunting of blood into low pressure circulation of chorioangioma. This diverts blood away from the functioning placental villi, thereby reducing its ability to provide oxygen and nutrients to the fetus. Yes, now you have diagnosed a chorioangioma. Now what are we supposed to do, or what are the things we need to evaluate? I will discuss this in step by step. Before that, we know that the two important risk factors are vascularity and size of the tumor. The first step is to assess the character of the tumor. We need to report the size. If required, 3D volume can be used, and we need to report the exact location and how far it is from the cord insertion. The next step is map the vascular supply. You need to document the number of vessels and location of the vessels, like whether it is single central or multiple or peripheral, like that. And then you have to even document the diameter of the feeding vessel. The clinical significance of this we will see later. So all these parameters, they will reflect the shunt burden in the chorioangioma. Step 3 is Doppler survey. Here we systematically evaluate three key areas, that is the umbilical artery to assess placental resistance and detect early compromise, and venous circulation, like looking at ductus venosus and umbilical vein for abnormal pulsation, which will indicate the progression towards cardiac decompensation, and middle cerebral artery Doppler, especially MCA PSV, to assess the degree of fetal anemia. Step 4 is assessment of amniotic fluid volume. The next step is to assess the fetal echo parameters. Evaluation of CCTC ratio, and when it is increased more than 0.5 indicates cardiomegaly. The next step is to evaluate the combined cardiac output and also to look for tricuspid regurgitation. Presence of severe TR or CCTC ratio greater than 0.5 or combined cardiac output exceeding 400 ml per minute per kg are all diagnostic indicators of congestive cardiac failure. Some studies also recommend the use of cardiovascular profile score to quantify the extent of cardiac dysfunction. A low cardiovascular profile score is associated with high risk of fetal demise and also adverse neurological outcome in these fetus. Now you have completed step-by-step evaluation of the tumor. If there is no abnormalities in your evaluation, then the case is usually managed with weekly ultrasound follow-up, and the interval can be increased if the fetus remains stable after 2 to 4 weeks. If any one of the abnormal finding is detected, like shown in the picture, but there is no high drops, then we move to close follow-up, usually twice weekly, with fetal echocardiography and having in mind early intervention if any abnormality progresses. If there are 2 or more abnormal findings, or if the fetus has already high drops, then the intervention should be actively offered. Once we decide for fetal intervention, the first step would be to correct the fetal anemia if present by intrauterine transfusion. If laser therapy is not available, then the various direct tumor management options like coil embolization, chemosclerosis by intratumoral alcohol injection have been described in the literature. Now, if we have decided for laser intervention, the choice of procedure depends upon both the placental location and characteristics of the feeding vessel. When the placenta is located anteriorly or fundally, performing fetoscopic laser photocoagulation becomes technically more challenging. In such situations, interstitial laser therapy or radiofrequency ablation are preferred treatment options. These methods are not only more feasible in terms of access, but also provide a reliable way to target and ablate the feeding vessel supplying the chorioangioma, as well as it is technically also relatively easy. If the placenta is posterior and the feeding vessels are less than 3 mm diameter, here comes the significance of diameter of the feeding vessels. Then single port fetoscopic laser for photocoagulation is usually performed. If the feeder vessels are 3 mm or larger, then 2-port FLP is preferred. Now this slide demonstrates a targeted in utero procedure used for chorioangioma. In the first image, you can see the placement of interstitial laser tip inside the tumor, directly targeting the feeding vessels. The Doppler image after the procedure shows complete absence of blood flow, confirming successful vessel ablation. The second illustration demonstrates a 2-port bipolar coagulation technique. This approach is chosen when the feeding vessel is larger in diameter, because single port laser coagulation may not be sufficient and could even risk the vessel rupture. So by introducing bipolar forceps, the feeding vessels are coagulated slightly proximal to the tumor before entering the chorioangioma. So this will reduce the vascular inflow, making the subsequent intratumoral laser photocoagulation easier and safer. Now let's move on to cystic masses of placenta. Placental cysts or cystic masses arising from the fetal surface of the placenta, often referred to as subchorionic or chorionic cyst. They protrude into the amniotic cavity and are usually detected on ultrasound in second or third trimester. In ultrasound, the cysts appear as anechoic, round or oval shape with a smooth thin wall, and it can be single or multiple as seen in this picture. The theory behind the formation of the cyst is that hypoxia and low perfusion leads to trophoblast migration and local hypervascularity. The trophoblast in turn secretes fluid into the cystic cavity, which is also associated with fibrin deposition or thrombosis around the lesion. These cysts are frequently located near the placental cord insertion site, and if it is large enough to compress the cord, it may interfere with the umbilical circulation. There are 2 types of placental cyst. One is simple cyst and another one is complex cyst. Like you see in the left top corner of the slide, you can see the cyst is very clear with anechoic appearance. These are simple cysts. The cysts seen here are all complex cysts where you have an echogenic area inside this cyst. The internal echoes in these complex cysts may be due to fibrin, or it can be also because of the hemorrhage. Most placental cysts are incidental and associated with normal pregnancy outcome. However, If the cysts are large, that is more than 4.5 cm, or multiple, that is more than 3, or those near placental cord insertion, may be associated with the complications. When the cysts are associated with intracystic hemorrhage, the prognosis may not be favorable. Complications include IUGR, preterm birth, and fetal distress, and rarely can be associated with placental abruption too. Such atypical cysts in first trimester scan could be incidental and transient, and they are generally not associated with any clinical significance if it is isolated and the fetus is structurally normal. Now let's move on to the cystic placenta. The incidence of molar pregnancy is approximately 1 in 1000, of which 55% are from Asian countries. We can see in the picture that the molar pregnancy is quite common in the Asian population, and there are two types of molar pregnancy. One is complete and partial mole. We will look into the pathophysiology of these mole. This figure explains the three major pathways involved in the formation of hydatiform mole. In the first pathway, a normal ovum is fertilized by a single sperm, but after fertilization the maternal chromosomes are destroyed or expelled, and the paternal chromosome then undergo endoduplication, resulting in monospermic androgenetic diploid complete mole with 46XX karyotype. In the second pathway, a normal ovum is fertilized by two sperm. Again, if the maternal chromosomes are destroyed or expelled, the resulting zygote becomes diploid, but it is entirely androgenetic in origin. This gives rise to dispermic androgenetic diploid complete mole with either 46XX or 46XY karyotype. The third pathway is in which a normal ovum is fertilized by two sperm, but without the expulsion of maternal chromosome. This creates a triploid zygote. If this continues, then it will form a triploidy. This triploidy is diandric triploidy, and it can manifest as partial hydatiform mole. But if the triploid zygote postzygotically undergoes diploidization, then several outcomes are possible. That is, if genome is biparental, then a viable fetus may form. If only paternal chromosomes are duplicated, it can result in monospermic androgenetic diploid complete mole, or in some cases it may either form a normal or mosaic fetus, or if two sperms have contributed, then it may lead to dispermic androgenetic diploid complete mole. An important practical point is that in diandric triploidy, the paternal excess drives the placental overgrowth so that the fetal parts are minimally formed. In digynic triploidy, the maternal excess favors fetal development. So the fetus is relatively better formed, but it will show the features of triploidy like severe growth restriction. Why are we so much concerned about molar pregnancy? This study involving 141 patients highlights the reason. Of total 141 patients, 23% opted for termination due to the increased risk of maternal and fetal complication. The remaining 77% chose to continue the pregnancy. Of the pregnancies which were chosen to continue, 37% ended in miscarriage and 16% developed maternal complication that required termination. 4% had intrauterine fetal demise. So ultimately only 43% resulted in live birth. However, even within these live births, 17% of the babies died before day 8, and among those who survived beyond day 8, only 83% remained alive. So this clearly demonstrates the broad spectrum of complications starting from miscarriage, maternal morbidity, fetal demise, and poor neonatal survival, which is why the diagnosis, monitoring, and management of molar pregnancy is of critical importance. When a molar pregnancy is seen along with a live fetus, there are three possible scenarios. In type A, this is the most common one. It is a twin pregnancy where one sac has complete mole and the other has normal diploid fetus with normal placenta. The next one is type B. This is a singleton pregnancy with partial mole. This presentation is relatively uncommon. Here, the fetus is typically triploid and severely growth restricted. One of the characteristic features of this severe growth restriction is it has disproportionate growth, with head being relatively larger when compared to the rest of the body. This is the hallmark feature of IUGR in triploidy. Next comes the type C, which is least common. It involves a twin pregnancy where one sac has partial mole with a triploid fetus, while the other sac has normal diploid fetus. If you look at the ultrasound images, the placenta in both cases look very similar. Both are cystic vesicular with snowstorm appearance. And by ultrasound alone, it is almost impossible to differentiate between these two conditions, especially the placental mesenchymal dysplasia and molar pregnancy. So how do we proceed further? This is what we will explore in the subsequent slides. So when we come across a cystic placenta on ultrasound, the next step is to see whether the fetus is present or not. If there is no fetus, this is most consistent with complete hydatiform mole. If intertwined membrane is present, then there are two possibilities. One is a dichorionic twin pregnancy with a complete mole and coexisting normal placenta with normal fetus. This comes as type A, and this is the most common form. And the next option could be a dichorionic twin with a normal fetus and placenta and another sac with partial mole of mixed twin. This is type C presentation. Now when we see a cystic placenta and the fetus is present but intertwined membrane cannot be made out or is absent, then the situation becomes more complex. Here we are looking at a structurally normal or a growth restricted, especially severe asymmetric IUGR and associated with a placenta that shows cystic changes. Now with this scenario, we have three major differential diagnoses. The first one is placental mesenchymal dysplasia, which can mimic molar changes, but the fetus is usually karyotypically normal. The second one is singleton pregnancy with partial mole and a triploid fetus. Here the fetus is typically severely growth restricted. And next one is confined placental partial molar pregnancy with a normal diploid fetus. This is a very rare condition in which the fetus has normal karyotype but the placenta shows partial molar changes. Now how do we differentiate them? In placental mesenchymal dysplasia, beta HCG levels are usually normal or only slightly increased in some cases, while maternal serum AFP is elevated. In partial mole, beta HCG levels are markedly elevated, but AFP is usually normal and karyotyping shows triploidy. In rare cases of normal diploid fetus with confined placenta partial mole, beta HCG is again high because of the molar component. However, none of these biochemical tests are confirmatory, and the definitive diagnosis comes from placental histopathology and by immunohistochemistry. Regarding the histopathology of partial and complete mole, there is hydropic swelling of terminal villi along with trophoblast proliferation of the villi. And in partial mole, part of the villi are normal, whereas in complete mole, almost the entire villi, almost all the villi are involved. But in the case of placental mesenchymal dysplasia, there is villus edema, but importantly, there is no trophoblastic hyperplasia or there are no trophoblastic inclusions. Now let's move on to immunohistochemistry. One is P57 and the other one is Ka67. Now first let us see P57. This helps to determine the genetic origin of the villi, whether it has derived from the both mother and father or only from the father. P57 gene is maternally expressed one and paternally it is completely imprinted. So in complete mole, which is completely androgenetic, all the genetic material derived from only from the paternal side, the P57 is totally absent. Whereas in the case of partial mole or placental mesenchymal dysplasia, where the genetic origin is biparental, all the villi will show P57 positivity. Okay, now based on P57 we have eliminated complete mole. Now what about differentiation of placental mesenchymal dysplasia and partial mole? Here comes the role of Ki67. The Ki67 staining takes place according to the degree of trophoblastic proliferation. So in the case of partial mole, it will be high because you have trophoblastic proliferation in partial mole. Whereas in placental mesenchymal dysplasia, there is no trophoblastic hyperplasia, hence the Ka67 staining will be low. Coming to etiology of placental mesenchymal dysplasia, it can be because of mesodermal dysplasia, or can be androgenetic biparental mosaicism, or can be disruption of imprinted genes and chromosomes. Hence, it can be associated with commonly with Widman syndrome, and even otherwise the fetus can have severe IUGR, or there is an increased risk of having intrauterine fetal death. Presence of molar pregnancy, whether complete or partial, is associated with the increased risk of serious complications, and these risks must clearly be explained to the patient as they becoming life-threatening at any time.
Thank you so much for watching. If you like this video, please subscribe and share to your friends.